Yes, hi. Hello, everyone. I would like to start by taking this opportunity to say how delighted I am to be amongst you today. It has been a great invitation to accept this time. It's always great when you have the opportunity to discuss important topics with patients. And therefore, within the next half an hour, what I will be talking to you about is recurrent implantation failure and reduced ovarian reserve. But firstly, I would like to start by obviously introducing myself. My name is Christos Venetis. I'm a fertility specialist gynecologist, and I'm also a clinician researcher. I am the clinical director of research for IVF Australia, and I also work with UNSW. So, as I said, I was very happy to accept this invitation, and I would obviously like to thank the organizers for giving me the opportunity to be amongst you today. And I was asked to talk about two particularly challenging topics, both of which, however, have been a keen clinical interest of mine and research interest of mine for many, many years. And that's recurrent implantation failure and reduced ovarian reserve. I have decided to break my presentation in two sections. In the first one, we're going to talk actually about reduced ovarian reserve, poor ovarian reserve, and what is the evidence, what can be done about it. And we'll have a break there and we'll try to answer any questions you might have. And I imagine you're going to have lots of questions. So please make sure you put those questions in the chat box so that the moderators can ask me those questions. And then we will proceed with talking about recurrent implantation failure, which is a different entity, is when we do get to have embryos, but sadly we put them back and nothing implants. And I would also present some things around the etiologies and the management of these patients and what can be done. And then I would be going on to discuss the questions you might have. So with no further ado, I would like to move on to my first slide. My first slide is all about what is the definition of reduced ovarian reserve. And the definition of reduced ovarian reserve has been recently suggested by a big scientific body of the European Society for Human Reproduction and Embryology, and they come up with a definition. And the reason they have come up with that definition is because essentially they had no way previously of understanding who truly represents such a patient. So moving on, I would say that this is the definition that we've all come to see. And as you can see here, that definition involves different characteristics, but predominantly is about having a lower number of eggs. And that is what most patients experience as poor ovarian reserve. Having said that, the problem comes with the fact that not all patients are the same. So as I was saying, this is the most up-to-date definition. And as you can see, this definition involves different aspects, including age, but predominantly includes a number of oocytes. But one of the things we have realized as we have researching in how to best treat these patients is the fact that not all patients are the same. And therefore, another definition has emerged recently, which essentially involves other characteristics like as how old you are. So a patient who has 3 eggs and is 30 years of age is entirely different to a patient who is 40 years of age and only has 3 oocytes or reduced ovarian reserve. And this is very, very important. And I would like to start this presentation by just making a very clear statement that in IVF, we do know that when we stimulate the ovaries, we stimulate the eggs that are ready at that point in time to be stimulated. Therefore, if at the beginning of that cycle, we do an ultrasound, as you can see on the left side here, we cannot see any eggs ready to be stimulated. Essentially, it doesn't matter what the dose or what other medication we involve in the stimulation regimen, we're not going to be having any eggs. We cannot stimulate eggs that are not there. And this has been a very key problem to understand, which allowed us to devise a number of different strategies in order to ensure that we'll get the very best out of our patients. I still have an issue with my slides. Not sure what's happening with the clicker. Okay. All right. So one of the first questions that people have been asking is, what should be my starting dose? Should I be on a high dose or should be on a lower dose? So the available research essentially has suggested that in most cases and for most patients, 300 to 450 units is the absolute maximum dose. And in many cases, especially when you have lean patients, even 300 might be too much. And the reason for that is because, as I said, you can only stimulate what you have. So unless you have a person that their body habitus is a bit bigger, they're a very tall woman and they have a higher body mass, then in most cases, 300 international units of gonadotropins would be more than enough. So pushing the agenda or pushing either your dose higher will not make a huge difference. Another very interesting concept is, what do we do after we start with the right starting dose? And one of the things that many of us try to do, or sometimes many of the patients ask for, is can we adjust the dose? Again, the research here is very interesting because it suggests that any adjustment in the dose you make will have at least 3 to 4 days before it can make any difference in the follicles. It will be at least 3 to 4 days before the body realizes that an increase in dose has been made. So changing the doses every 1 or 2 days, in many cases, does not make much sense. Whereas selecting the proper starting dose, as we said, might make a huge difference. In that aspect of things, and having that in mind, we did some research a few years back where we wanted to see, when we do have women with reduced ovarian reserve, can we make things easier for them without necessarily compromising their cycle? So we designed the randomized control trial, which is probably the best type of study you can do in order to find out the answer. And we wanted to see whether if we gave one single long-acting dose of corticotropin, which is 1 injection for the first 7 days, whether that would be equivalent to just giving 450 units on a daily basis. So essentially, can we, just by giving 1 injection for 7 days, substitute 7 injections? And that, for many patients that go through many cycles, might be very, very significant. And when we did that study, what we actually realized is that indeed, it seemed that there was no difference both in the number of oocytes retrieved or in the clinical pregnancy rates. So that study, once again, showed us very clearly that if you have the right dose in the beginning, you can probably simplify your stimulation schedule as much as you can and make the treatment as patient-friendly for the as possible. Another common question that many patients ask is, should I be adding any other type of gonadotropins? And one of the theories that was there for quite some time is that if we add another type of gonadotropin, LH, Luveris, which is the actual brand name that some of you might know, then this might make a difference. And we did have some evidence at the beginning that said that, yes, this indeed might make a difference, until a very big randomized control trial happened involving around 940 patients that were true poor responders. But sadly, that study failed to show that there was any difference in terms of either the number of eggs retrieved and, importantly, the number of babies were born between patients that did receive extra LH, extra Luveris, and patients that just stayed with the regular FSHs. So the message from that study was essentially that if there is an indication, if there are some patients that can benefit, we still don't know exactly who they are, and we're still trying to find out what is the patient profile for these patients. The next interesting intervention that many of you might have read out there is androgens. And by androgens, we mean DHEA and testosterone. And we were amongst the first to actually suggest doing a meta-analysis that this might be beneficial. And that was, again, about 10 years ago. But subsequently, we did an actual randomized trial ourselves in our study, in our unit, not here in Greece, where I started my training. And we were unfortunately not able to see a huge benefit by using transdermal testosterone. Nevertheless, including all the studies that have been published today, if we put all the studies together, with transdermal testosterone, there's still some evidence that might increase the number of eggs that a poor responder can have at direct collection. And importantly, there might also be a benefit in live birth. These studies are not huge or not very strong in terms of the evidence, but they do represent some evidence in favor of using transdermal testosterone. Interestingly, with transdermal testosterone, another important intervention that has been proposed is DHEA, and the evidence there is even more contradictory and conflicting. However, if you put all the evidence together, which are of not the strongest methodological quality, a benefit is still implied. Another intervention that many patients ask, or you might have read online, is growth hormone. And once again, this being an area where I'm very much interested in, we had done a systematic review and meta-analysis about 12 years ago, where we were probably the first group to show that, yes, based on the available evidence, it seems that growth hormone might be able to help some poor responders. But that was again based on very old studies, the methodological quality of which was very, very weak. So since then, many things have happened and new meta-analyses have risen, but sadly, the evidence that we have is very, very weak to be able to confidently support that growth hormone makes a difference. Therefore, all these interventions, testosterone, DHEA, growth hormone, there are interventions for which you can certainly find in the literature some evidence in support of their use, but saying that unanimously or overwhelming evidence, the overwhelming evidence is in favor of their use is not true. Every single time one of your doctors will be discussing this with you, I'm pretty sure they will be going through the quality of the evidence and the fact that we don't have great confidence in whether something like this can help you. And by discussing this, hopefully it will allow you to make an informed consent on whether or not you would like these to be used during your cycle, especially when some of these can have side effects, important side effects, or have a significant cost, unless you know for a fact that it can make a positive difference. Probably using those interventions is not something advisable. Do we have other strategies, apart from these adjuvants? There are some other strategies that have been proposed, and I'm going to go briefly through them in the next few minutes. So one of those strategies is whether, for example, instead of fully stimulating the patient and giving them high dose of phasages, could we, particularly in extreme poor responders, could we adjust a different strategy and try and collect multiple oocytes from natural cycles, meaning even without any stimulation, and try to collect multiple oocytes and create multiple embryos before attempting an embryo transfer. Again, with the colleagues in Athens, Greece, we did a study that was published in Human Reproduction, where we were able to see that patients that had opted to go through repeated modified natural cycles, compared to patients that were just heavily stimulated, had a significantly higher chance of having a live birth compared to those that opted for the stimulation. Whether that was an element of the fact that we had the opportunity to collect eggs from multiple different cycles, and therefore we had a higher chance of finding really good quality oocyte or not. That's not something that could be deducted from that research, but that finding was generally was very, very interesting. And this is something that many couples opt to in Europe. Sadly, in Australia, this is not an option which is as straightforward for Australian patients, since the current system of Medicare rebate does not allow for multiple cycles within 1 month. In that similar fashion, others, researchers from other parts of the world, like for example here from Italy, have suggested within 1 cycle to try and have 2 egg collections. And I know that most of you think that the egg collection should happen around the middle of the cycle, and that's how nature has predicted it. But with research in the last few years, we have realized that actually during a woman's cycle, there are multiple waves of eggs that can be potentially recruited if we stimulate them. So in some scenarios, this is a very interesting study from Italy. Some patients might actually benefit from having 2 stimulation cycles within 1 month. How does that work? You give them some stimulation for about 10 days, you do the egg collection, and then 2 to 3 days after the egg collection, you start another stimulation, and usually within another 10 to 12 days, you'll be able to collect more oocytes. And importantly, what this study has shown that it doesn't really matter whether you collected the oocytes, the eggs from the first half of the cycle or from the second half of the cycle, they would still be comparable in terms of their capacity to give a baby. So that's another strategy that we use many times. And again, as I said, in Australia, unfortunately, it's not easy for the reasons that we've discussed in terms of Medicare rebates, but that's something we do in Europe many times, especially when we're running out of time and we want to select as many eggs as possible within a limited amount of cycles. Again, I do apologize for the lag. It seems that I'm having some issues around advancing my slides again. Yeah, so to conclude in terms of this first part of my presentation, and obviously I've just touched on the major interventions that are out there, but I'm very, very happy to discuss any other question that you might have. We do know that there is a number of patients that can fall under the reduced ovarian reserve category. Not all of them are the same. And your specialist, your fertility specialist, will be the one to actually advise you on which category you potentially might fall. And depending on the category you might fall, the prognosis actually is going to be significantly different. So for that same reason, you have to be very aware of that when you're actually reading things online, because not every poor responder is the same. Some poor responders, as I said, are young or have a lower number of eggs, but they have excellent quality of embryos, and some other poor responders actually cannot even produce any embryos. So these are entirely different prognostic categories for patients, and we need to ensure that every patient is managed according to the specific category they belong into. So in terms of interventions that are out there, what we discussed is that starting and making sure that your patient is properly stimulated is key. Going with very, very high doses is very rarely, if at all, beneficial. So for most patients, as we've said, 300 to 450 units would be enough. And changing the dose many times throughout stimulation probably does not make any difference. In terms of adjuvants, many things have been proposed. Adding Luveris or recombinant LH is something that was very popular, but now we know that we still do not know exactly which patients might benefit from it. So it is something that we need to be very well aware of. Testosterone and DHA co-treatment seem to increase the chance of live birth. However, the evidence that support this benefit is very, very weak, and that's also something that should be clearly communicated to the patient. It might very well be the scenario that it might work for some patients, but for some others, it doesn't do any difference. And of course, the problem is that we still don't know which patients should be getting these types of treatments, and that's the key challenge. In terms of growth hormone, also the evidence that we have is conflicting and of poor quality, but I think for most of us, the overall impression is that it doesn't make a significant impact in terms of live birth rates. And again, you might be able to find in the literature studies that say that yes, it does. But when you evaluate the total body of evidence together and you look at the quality of the studies, then probably you don't have much confidence in this intervention. But again, this is something that you should be discussing with your doctor. Finally, there's a number of alternative strategies where we're trying to essentially collect more oocytes before transfer, either by doing, for example, drug-free, in a way, natural cycles repeatedly, or either by, for example, stimulating women twice in one menstrual cycle. These strategies have shown promise. They're particularly challenging to implement in the Australian context, but in the future that might change. So to close my first session, and before I hear your questions, which I hope you have submitted by now, but please, if you haven't, I encourage you to do so now. I do understand that poor ovarian response and reduced ovarian reserve is a significant issue, and it's one of the most clinically challenging things to manage as a fertility specialist. We do have certain strategies to help individuals. Most of the times it will depend on on the reason why you might be having reduced ovarian reserve. But importantly, one thing I would like to make sure it's clear is that in many cases, even women with reduced ovarian reserve still end up having children either through IVF or using other methods of medically assisted reproduction. So you should ensure that if you do belong in that category, do not get discouraged. Make sure you have these discussions with your fertility specialists, and hopefully soon you'll be able to celebrate a successful outcome. I'm not sure whether the moderator would like to come online now and discuss any potential questions that might have been submitted.
Yes, Christos, it's Marie here, and I'm delighted to help facilitate some questions. So with our audience, just remember that when you're viewing this presentation in the platform, there is a question box immediately below the video viewer, and you can enter your question there. Other people won't see it, so it is private, and I'll be able to moderate that and feed that to Christos. So I do have a question for you, Christos, and that is, what are the common causes of reduced ovarian reserve? I mean, why does it happen?
Well, it is a very important question, because again, it goes back to what are the reasons that we're there. Obviously, there are women that are naturally have reduced ovarian reserve. And what do I mean by saying that is that if you are over 40, then nature has already dictated that women over the age of 40, and most of them will have reduced ovarian reserve. So in some cases, it's just a byproduct of age, because as we all know, as women age, two things happen. The quality of their eggs deteriorates, and importantly, their ovarian reserve, the pool of follicles that they have in their ovaries reduces in size. That's the natural. These are women that combine a reduced ovarian reserve with advanced reproductive age, as we say. And there's nothing essentially that needs to be explained there. In most cases, it's very simple. But there are other situations where you see a 31, 32-year-old woman who has abnormally low ovarian reserve. In these cases, there's a number of potential explanations. For example, it could be something like she had surgery at some point, which might have affected one or both of her ovaries in a way. She might have one of her ovaries removed due to an ectopic pregnancy or due to a severe infection. And essentially during that surgery, unfortunately, one ovary with the eggs had to be removed or was destroyed. It could be the byproduct of or the result of a pelvic inflammatory disease. It could be the result of other treatment she might have had when she was younger. Like, for example, we know for a fact that women that undergo chemotherapy with certain medication might end up having a reduced ovarian reserve in the future. Smoking can affect the number of oocytes that are left in the ovary significantly. A number of autoimmune diseases can also cause issues and can lead to a reduction of the ovarian reserve. And there is a number of genetic issues that we know of that are associated with reduced ovarian reserve. For example, women having a pre-mutation, being essentially almost carriers of a condition we call Fragile X syndrome, that might also predispose to having lower ovarian reserve. But what is important is in many, many cases, we do not actually have an answer. And that means we call these cases idiopathic. That means essentially that there's probably a genetic condition, some reason, some underlying reason, which could be part of their genes, or it could be part of an event that happened when they were even in their mother's womb as little fetuses, that reduced the number of follicles and eggs that they had. And now we cannot really ascertain what is the cause. And in those cases, probably they're the most frustrating because there are no other symptoms, and these women all of a sudden get delivered the really bad news that they're running out of eggs. These are the challenging situations, but we need to make sure that the patients are well supported, and most importantly, understand what are the options ahead of them in order to maintain their reproductive autonomy and have the family they always wanted.
Well, that was certainly a comprehensive answer. There's really a number of causes of reduced ovarian reserve, and it sounds like for anyone who has concerns, who has not yet seen a fertility specialist, this is the type of diagnosis that really has to be done in concert with a fertility clinic, not just with your GP. Would that be fair?
Oh, absolutely. This is, in most cases, this go well beyond the services that the GP can provide, and GPs know that. So they would be amongst the first to refer you to a fertility specialist, so that essentially proper diagnostic investigations, proper diagnostic is made, and a diagnosis is made, and importantly, proper therapeutic options are offered to their patients.
Well, I do have a question here. Someone's going, well, I've been told that I've got reduced ovarian reserve. I did get some tests done. Does that mean that my eggs are going to be of poor quality? Is that what that really means?
Yeah, no, that's a very important question. Thank you, Marie. And I sort of alluded to that. No, the answer is no. Many times I see almost on a daily basis in my practice, and women that come here in tears because they've just been handed over a diagnosis of a low AMH. Many women do that AMH, which is essentially a blood test that can show you where your ovarian reserve seems to be. And for some women, it's going to be low. So they come in the clinic thinking that that means they're infertile and they need to have IVF straight away. So particularly for young women, that's rarely the case. In most scenarios, when we have young women where the reason for their low AMH is just some genetic reason we cannot identify, the quality of their eggs is still going to be very good and reflective of their age. So in those cases, what we usually do is we advise these women to complete their family as soon as possible. And if they do not currently have a partner, potentially other options like egg freezing could be on the table. So if you're young, and by young, I mean if your age probably is, if you're less than 37, even if you have a low AMH, you still have a very good chance of conceiving. And in many cases, it could be even naturally. It doesn't mean that if you have low AMH, you need to conceive via IVF. Many women that had low AMHs, they went on and completed their families just by conceiving naturally. So having a low AMH doesn't necessarily mean IVF. However, I would probably still advise these women to see a fertility specialist so they understand all their options and they're properly investigated. On the other side, on the other hand, if you are someone who potentially has other issues, like if you have severe endometriosis and that is the reason of your low AMH, or if, for example, you have advanced reproductive age, you're 41, 42, then on the basis of endometriosis and or advanced reproductive age, your egg quality could be affected. And in these cases, we need to see what can be done in order to optimize the chances of a pregnancy for that woman.
Well, thank you for that, because I think our viewer would be encouraged in knowing that it doesn't mean that the eggs are necessarily of poor quality, but it does need to be investigated and options weighed up. Now, you've got your second part of your presentation focusing on recurrent implantation failure. If you move on to that, I would just tell you that the advice from our technician is that maybe if you just say next slide, he can advance the slide for you.
Yes, thank you. I will do. So if we can just bring the slides up, that would be great. So as I said, the next, please, next slide. The next aspect would be recurrent implantation failure. And as I said, this is not when we just have failed IVF cycles because we didn't have any embryos grown. It's when we put back perfectly good-looking embryos and sometimes even genetically tested embryos and nothing works. And this is a heartbreaking experience for our patients because they are so hopeful. They have a beautiful embryo to put back we put it back, it doesn't work. They put a second back in, it doesn't work. And then all of a sudden, they start thinking, what is wrong with me? Is it something with my body? And it's a very challenging situation to go through. And it has, again, been one of my clinical, on the areas of clinical interest of mine for many, many years. Next slide, please. So much so that with a colleague of mine a couple of years ago, we put together a textbook on recurrent implantation failure, on what can be done, what are the etiologies. This is obviously a textbook that is not for the lay reader, it's for doctors, but it offers a very up-to-date approach on how we can manage using evidence the patients that have recurrent implantation failure. Next slide, please. And I would like to start by saying that because many patients come to me saying, oh, we've looked online, Dr. Google, we've looked in the studies, and we would like to try this, we would like to try the other. One of the important things that people should know is that many of the studies that have been published use entirely different definitions of what is a patient with recurrent implantation failure. And that creates problems because what you're reading online might not actually be suitable for you. So you should always be asking your doctors on whether you feel something that you've read might be appropriate for them. Next slide, please. So when we're talking about recurrent implantation failure, two things we need to have in mind. We have to see how many times was an embryo transferred and what kind of embryo was that. Next slide. And the reason for that is because we know that if we say, for example, we have a good quality embryo, when we put it back, it has about 30% chances of taking. But then it means that 70% of our patients will not get pregnant because the embryo was not good. And therefore, if we use the probability theory, we can see that if we've had 3 embryos put back, about 1/3 of our patients will have not conceived after 3 embryos put back, not because there is something wrong with them, but because essentially simply they were not lucky. Next slide, please. And this is very important because you don't want to overdiagnose a patient or overtreat a patient. So the quality of the embryo obviously is also very important. Next slide, please. If you have a good quality embryo, it's entirely different to putting back a bad quality embryo. Next slide, please. Click. And this is the blastocyst. You can see a perfectly nice blastocyst on the left and a not so great blastocyst on the right. Next slide, please. So if, for example, we assume that the embryo we have is not looking great, and in that case, we have 10% success rate per embryo, and that could be for a woman who's 41, for example, 42. Then after 3 failed embryo transfers, we'll see that essentially 73% of the women who would have had at 41, 3 embryos put back, they will not be pregnant. In this case, these women, the main cause of their struggles to get pregnant is not the lining, is not their immune system, is the fact that the embryos look good, but they don't have the right genetics. Therefore, they have not yet properly had the right opportunities to get pregnant. Next slide, please. And this is very important because unless we standardize these things, we will never be able to properly treat patients. Some patients come and see me being very distressed, thinking that something is terribly wrong with them. And then when I go through the cycle, I essentially explain to them that I understand you've had 3 embryos put back, but if we look at the embryos, I do not think that it's unreasonable and something out of the ordinary that you have not conceived yet. And that's something that patients should be aware of. Obviously, we're trying to get them pregnant with the first go, but most of the times, this will not be the case. And we have just to insist and we have to ensure that we're doing everything right to get them pregnant. Next slide, please. So, as I said, in order to fix any issue, we need to understand its underlying physiology. And for that reason, one of the first things we need to make sure is that we're using, we have good quality embryos. Next slide, please. So this is the main question I ask myself, and I encourage all my colleagues to be asking themselves whenever they're seeing a patient that had repeated implantation failures. Is this a patient truly a patient affected with this phenomenon, or they might have been just unlucky? Next slide, please. And then how can we make sure we give every embryo the best chance to implant? By optimizing their lifestyle, making sure that the weight is appropriate, they do not smoke, their alcohol consumption is minimal, if any, they don't have any endocrine chemical disruptors in their everyday life. And obviously these patients need to be supported because, as I said, it's a devastating experience and the patients have very distinct psychosocial needs around that time. Next slide, please. So we have to look at the genetics because in some cases that might be the explanation. Next slide, please. There are studies available that show, next, please, next slide. Next slide. That show that in a small proportion of patients, we do have problems in the genetics of the couple that might be responsible for their embryos not implanting. Next slide, please. However, the overall proportion is still very, very small. That means that, yes, we will look for that, but we do know that in most cases that will not be the reason. Next slide, please. So if, however, we do find such a problem, then we can discuss things like having genetic pre-implantation genetic testing, or depending on the wishes of the couple, oocyte donation or sperm donation. Next slide, please. So there are other factors as well, factors that are related to the uterus. And we can see that in some cases we have congenital uterine anomalies like septa or having a double uterus. This is sometimes problems that can have been implicated in affecting women with the recurrent implantation failure. Fibroids, endometrial polyps, infections in the uterus, hydrosalpinges, and certain interventions have been proposed. Next slide, please. So we've done a lot of research, and for example, in terms of congenital uterine anomalies, we have seen that the evidence is not entirely clear that they affect implantation. And that means that if you have a septum, there is a chance you might suffer a miscarriage, but it's not very likely to be the main cause of repeated implantation failures. Next slide. A very common for many of us, a reason for women to have repeated implantation failures, particularly if before they had any type of surgery or instrumentation of the uterus, like after a miscarriage, for example, could be a chronic endometritis. Essentially, that's a chronic infection of the lining. And in order to diagnose that, next slide, please, we usually do a hysteroscopy and we take a biopsy. And the encouraging thing is, next slide, please, that by using antibiotics when this is diagnosed, it can actually be very successful. Next slide, please. This is a study that has been done by where we've seen that when women take antibiotics with chronic endometritis, the chances of them getting pregnant after a successful treatment is about 7 times more than if they don't get any antibiotics. And interestingly, if you compare women with cured endometritis, cured infection of the lining, versus women that never had infection of the lining, the chances of implantation, the chances of having a pregnancy are the same. So chronic endometritis might be an issue. It does require getting a biopsy, but when we do see that and we cure that, then the result in most cases will come back to being exactly as it should be for that woman's age and overall prognosis. Next slide. So other things that patients and doctors should be looking into is making sure that the thyroid function is fine. It's a very significant problem is diabetes mellitus and insulin resistance, which can interact with the process of an embryo implanting. And therefore, they need to make sure that we have endocrinologists on board to optimize their glucose metabolism. Vitamin D levels should be optimal. And therefore, in many cases, we need to, as I said, involve an endocrinologist. Next slide, please. A very contentious topic is that of immunological causes. And that's probably what most patients think after a few failed embryo transfers. They say something is terribly wrong with me. My immune system is killing my embryos. And there is a number of investigations that have been proposed, and there is a number of treatments that have been proposed. Interestingly, this is a topic that still is far from settled in terms of whether we all agree on what should be the specific tests that the couple should undergo. We're not even certain how to interpret, in some cases, these types of tests and whether indeed they make a difference. And the same applies. For example, many women will be put on steroids. That might be something that you should be considering at some point, but in many cases, that's not warranted at all. One of the things that we were doing for quite some time was the endometrial scratching. And interestingly, in the past, we felt that that might be, something advantageous. Next slide. Until more recently, a couple more studies came about which challenged that idea. And the most recent and up-to-date probably knowledge on this topic is that endometrial injury might confer benefit with women with recurrent implantation failure, but the evidence we have is very, very weak. So if your doctor is suggesting that, they should, and they will, I'm pretty sure they will be discussing with you that this might not be advantageous at all. Next slide. Thrombophilia or blood clotting disorders has also been suggested to be involved in women with recurrent implantation failure, especially when you have what we call combined thrombophilia. The studies, next slide please, are not many. We have a study also coming from Australia, but until today, we consider that this field is a field more relevant to researchers rather to clinicians. So many times we'll see individuals coming that have had some tests, and they will have, for example, an MTHFR mutation. And what we do think so far is that probably it's unlikely to affect whether that woman will get pregnant or not. So I do understand that in many scenarios, most women try to find an explanation on why they have not gotten pregnant, and anything that might be out of the ordinary and might be mentioned on the internet might be something they're very keen to cling on. But you have to discuss these things with your doctor, and they should be able to give you advice on whether, for example, these types of many times naturally occurring variations in terms of genes have any effect on your ability to have a pregnancy. Next slide, please. So coming now to the end slides, sperm DNA fragmentation is something else that we do. We know we have some evidence that it might be associated with miscarriages. We're not so certain about recurrent implantation failure. Again, this is an area of research, and this is by far not something that we should be using on a routine basis for our patients. Next slide, please. So probably one of the best things you can do when you're having a patient with recurrent implantation failure is make sure that you do all the little things right. Next slide, please. And by doing all the little things right, you'll probably end up having marginal gains, but these marginal gains might be what will essentially help the woman or the couple get over the hump and get pregnant. Next slide, please. So standardize and optimize. This is always my advice to other doctors and to patients. We need to ensure that these things are consistent in order to be able to fine tune and potentially help us find the time and the right embryos that can help these patients get pregnant. Next slide, please. So one of the things that many people have proposed is doing genetic testing, especially when we fear that the reason why these women are not conceiving is because their embryos are not genetically normal. And a recent study has suggested that in women that have put back genetically normal embryo, less than 5% of them actually will be affected by recurrent implantation failures. And that shows how important is the embryo and the embryo quality in the whole clinical spectrum of recurrent implantation failure. Next slide, please.
Christos, we'll need to look at with your final slides, if you could. Thank you.
That's fine. That's absolutely fine. So I would like to finish by saying, by doing simple things, recurrent implantation failure is something that in most cases can be managed quite efficiently. It is important to have the proper advice by your clinician, and not to necessarily rush into having expensive diagnostic or therapeutic interventions. Marie, that was my final slide. I'm happy to answer any questions we might have there.
Yes, thank you. It was just such a information-packed session. I think really people have benefited from getting two presentations in the one time slot. So they're very fortunate, because I think they're going to have a lot of questions to take back to their fertility clinics. We've reached the end of our time. I do have to encourage people to look at their next session. I want to take this opportunity, Christos, to thank you very much for your time today, for sharing with us your learned experience and research in researching the reasons for reduced ovarian reserve and how they could how it could be addressed with treatment options. And then also one that I personally can relate to, recurrent implantation failure, understanding that there are investigations that can take place, there are certain treatments that could be done, and this could make all the difference. So they shouldn't despair, they shouldn't give up, they should realize that by having a frank discussion with their clinic, there's an opportunity to look further. So a very brief closing comment from you.
First of all, thank you for the invitation. And I do agree with you. The key message is there are many reasons why things might not be working. Trust your fertility specialists, ensure you have an open discussion with them, and allow them to do their best medicine and their best science. And in most cases, things eventually will be fine. So thank you for the opportunity to have this discussion with you, and all the best with the rest of the conference of the Expo.
Thank you, Christos. So to our viewers, thanks for your participation. We would encourage you to provide feedback on this particular presentation by looking at the box at the bottom of your screen where you can click on poll and provide feedback. Then don't forget to check the agenda to see what's next in our 2 presentation rooms, the main stage and the breakout room, or the couch time panel discussion. There's also the exhibit hall where you can visit a number of booths. There's some 20 booths, and they've all got videos and material that you can download. And even for those of you who decide that you're happy to register to compete in the leadership board, there's some great prizes to be won that is a result of your activity visiting the sessions and the booths. So again, thank you very much, Christos. That brings us to a close, and we look forward to more events like All About Fertility Expo in the future. Bye, everyone.